This is your yearly sepsis update. The session will cover the definition of sepsis, common causes and risk factors, the use of EOBS on vitals with red flags, the Sepsis 6 bundle, monitoring and safety netting information for our patients. There will be a short assessment at the end. Did you know sepsis affects at least 245,000 people each year in the UK alone, and 48,000 people lose their lives as a result of sepsis? Around 40% of sepsis survivors suffer life-changing after effects. These effects vary, but include physical, psychological, and cognitive. These can be things such as memory loss, poor concentration, post-traumatic stress disorder, insomnia, repeated infections, hair loss, and lethargy. What is sepsis? Sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection, which in basic terms means it's a life-threatening condition that arises when the body's response to an infection injures its own tissues and organs. The infection causing sepsis can be bacterial, viral, or fungal. There are 3 stages to infections and sepsis. Infection is the presence of organisms in a normally sterile part of the body, or a localized inflammatory response thought to be organisms in any part of the body. There's sepsis, which occurs when infection produces an abnormal immune response resulting in potentially life-threatening organ dysfunction. And then septic shock, which is a subset of sepsis where particularly profound circulatory, cellular and metabolic abnormalities substantially increase mortality. It is clinically defined by a vasopressor requirement to maintain a mean arterial pressure greater than 65 milligrams of mercury, plus a serum lactate greater than 2 that persists despite adequate fluid resuscitation. It is extremely important to consider sepsis with any deteriorating patient that has signs and symptoms of infection, because there is not one single sign for sepsis. It always starts with an infection, as it's the body's overreaction. Generic symptoms are slurred speech or confusion, extreme shivering or muscle pain, passing no urine all day, severe breathlessness, feeling like you're going to die, and the skin that is mottled or discoloured. Any infection can lead to sepsis. The most common infection precipitating sepsis is pneumonia, with approximately 50% of all cases caused by pneumonia. The percentages go down as shown on the slide, with UTIs and pyelonephritis at 20%, abdomen, appendicitis, gallbladder and peritonitis at 15%, skin, cellulitis or surgical wounds at 10%, and rarer causes like meningitis, line infections at 5%. Anyone is at risk of sepsis. It does not discriminate. However, there are people that are at increased risk. These are the very young or very old, those with an impaired immune system. This includes treatment for cancer with chemotherapy, impaired immune function, for example, sickle cell, diabetes or splenectomy, taking long-term steroids, taking immunosuppressant drugs to treat non-malignant disorders such as rheumatoid arthritis, people who have had surgery, trauma or invasive procedures within the last 6 weeks, people with breaches to skin integrity, those that misuse IV drugs, people with indwelling lines and catheters, people who are pregnant or have given birth or had a termination or miscarriage within the last 6 weeks. If we look at this list, I think it would be difficult to find a patient within the hospital that doesn't meet at least one of those criteria, which is when there's a deterioration, we always ask you to think, could this be sepsis? Maternal sepsis is defined as a life-threatening condition due to organ dysfunction resulting from infection during pregnancy, childbirth, postpartum period, post-miscarriage and post-abortion. Despite improvements in the last 20 years, it remains one of the most common causes of maternal death. Pregnant people greater than 20 weeks, or those who have been pregnant within 6 weeks, must have their observations done on the MEOWS chart, which is currently on paper, as the scoring and red flags are different. Women are at increased risk during pregnancy if they have an impaired immune system, have diabetes or gestational diabetes, have required invasive procedures, have prolonged rupture of membranes, have had or have been in close contact with somebody with group A strep, have continued vaginal bleeding or offensive vaginal discharge. Neutropenic patients, due to their compromised immunity, are at increased risk of sepsis. Neutropenic sepsis is a potentially life-threatening complication of neutropenia. a low neutrophil count. It's defined as a temperature greater than 38 degrees and any symptoms and/or signs of sepsis in a person with an absolute neutrophil count of 0.5 or lower. Neutropenic sepsis should be suspected in any person with known neutropenia or risk factors, who have signs or symptoms of infection, who become unwell, have a temperature greater than 38 or are hypothermic, or has clinical features of sepsis, or there is a concern from a relative or carer that there is a change in their appearance or behaviour. There is a door-to-needle time for patients presenting to ED. We have 1 hour from the patients entering the department to administer antibiotics for those with suspected neutropenic sepsis. There is a tool available on KNET and in ED. The AMU team, the Acute Malignant Haematology Oncology Outreach team, are a great resource for support with neutropenic patients, and they carry bleep 844. There are several reasons to screen a patient for sepsis. These include a clinician or carer is worried about the patient, the NEWS2 score is 5 or more, there's evidence of organ dysfunction or red flags, so 3 and 1 parameter of the NEWS2 score, or there is a risk of neutropenia. Those red flags include a respiratory rate of 25 or more, or a new need for oxygen to keep the SATs above 91%. Both of these are a sign of respiratory dysfunction. A systolic blood pressure 90 or less, or a drop of 40 from their normal baseline, or a heart rate over 130 beats per minute are both a sign of cardiac dysfunction. No urine output for 18 hours or less than 0.5 mils per kilo per hour for catheterized patients is a sign of renal dysfunction, and anything other than alert on the ACVAPU score is a sign of brain dysfunction. Other red flags that should raise concerns are non-blanching rashes, mottled skin, which will appear fine, bluish, red light lace pattern on the patient's skin, ashen, where the patient will appear grey in colour, or cyanotic, where the patient will appear blue around the mouth and nose, or if it's centrally, or blue or cold peripheries. Or anybody who is neutropenic or has received chemotherapy within 6 weeks. The first part of your sepsis screening for patients who trigger on their NEWS2 score are: does the patient have signs or symptoms of infection? As sepsis is the body's overwhelming response to infection, it's unlikely to be sepsis in the absence of those signs. If they do have signs of infection, you should answer yes and complete the site of infection if known. You should answer yes to sepsis if you as a clinician or a relative are concerned, or the NEWS2 score is triggering and there is a suspicion of infection, signs of organ dysfunction. If the patient has a previous episode of sepsis open on vitals, it may ask you, is this a new episode of sepsis or is the patient still being treated for sepsis? You must tick the appropriate option for that patient. If you have answered yes to sepsis, the formal screening questions must be answered. It's important to take time to answer these carefully, as they make up your risk level of low, moderate or high. If the patient has had a lactate taken in the last 6 hours, this can be used for this assessment. There was an upgrade to the system in April 2024, where there are additional questions asking about the risk of neutropenic sepsis or a new or increased need for oxygen to maintain saturations. Sepsis is a medical emergency and requires immediate action. The Sepsis 6 was developed by the founders of the UK Sepsis Trust in 2005 as a solution to a set of complex guidelines introduced by the International Surviving Sepsis Campaign. First element of the Sepsis 6 is a clinical review. A senior review of patients triggering high-risk sepsis is key to ensure we are treating them for the correct condition. Any grade of doctor can initiate the Sepsis 6. Only a senior doctor, ST3, registrar or above can de-escalate the pathway and decide not to treat for sepsis or treat for a sepsis mimic. If the doctor is not treating the patient for sepsis after a clinical review, they should de-escalate the sepsis pathway on eVitals. Second element is oxygen. There is a crucial imbalance between oxygen supply and demand during sepsis. Correcting hypoxia will reduce the risk of complications. Always aim for the patient's normal target saturations. Third element is IV access and bloods. The following blood should be sent: blood cultures, ideally before antibiotic administration, but the antibiotics should not be delayed if there are difficulties in obtaining samples. You also need to send glucose, lactate, full blood count, Usinase, CRP, clotting, LFTs, and either a venous blood gas or an arterial blood gas for quick reference samples such as lactate. Other samples such as urine, sputum, wound swab should also be taken to help identify the source of infection. Fourth element is IV antibiotics. Broad-spectrum antibiotics are given to patients for sepsis of unknown origin. Tazocin is the first line and meropenem for those with penicillin allergies. Antibiotics should be targeted as soon as possible, so if there is a clear sign of the source of infection, appropriate antibiotics should be prescribed. They should be reviewed every 24, 48 and 72 hours to ensure that samples have been reviewed and that the patient is on the correct antimicrobial therapy. Fifth element is IV fluids. Administering IV fluids is essential for many sepsis patients. Those with a systolic blood pressure of less than 90 or a drop of 40 from their normal baseline, tachycardia, not passing urine or a lactate greater than 2. Adequate fluid resuscitation is up to 30 mL per kilo. Each patient should be assessed individually regarding fluids as they may not be appropriate for all patients, or the initial recommended bolus of 500 mL may need to be reduced for patients who have cardiac failure. And monitoring. Monitoring is essential to ensure treatments are effective. We should complete observations as per protocol or more frequently if you are concerned about the patient. There should be an accurate fluid balance and catheterization should be considered if it's appropriate for that patient. We should be monitoring the lactate until it has normalized, and patients not responding to treatment within an hour of administration require a consultant review and a possible ICU referral. When we've completed the elements of the Sepsis 6, these should be ticked off on eVitals as part of the Sepsis 6 checklist. Safety netting is extremely important for our patients. They need to know the signs of sepsis and when to seek help if they are deteriorating with an infection at home. All patients on discharge should be given the Just Ask Could It Be Sepsis leaflet, which are available in your areas, and any patients leaving ED or outpatients with antibiotics should also be given this leaflet. Patients diagnosed with sepsis during their admission should be referred to the KGH sepsis team via Careflow Connect for a follow-up pre-discharge and then to allow us to follow them up once they're into the community so they can be referred for our sepsis survivor support groups. KNET has several links and resources for more information on sepsis. You can contact the sepsis team on extension 1593 or bleep 652 or on our shared email kgh-tr.sepsisnursepractitioners@nhs.net. Thank you for listening. Please complete the assessment to obtain your competency.